Successful treatment of schizoaffective disorder with akinetic catatonia in the setting of past COVID-19 infection. The prevalence and relationship of COVID-19 and neuropsychiatric sequelae is not fully understood. Several cases of COVID-19-induced catatonia have been reported. We present a case of late-onset akinetic catatonia with successful treatment. A 39-year-old married African-American woman with a past medical history of COVID-19 infection and no psychiatric history presented to the emergency department with paranoia and delusions. In the ED, she endorsed a recent onset of recurring headaches and a feeling that her email had been hacked by her upstairs neighbors. She also stated that she had contracted COVID-19 5 months prior. During the interview, the medical provider noted that she became less talkative and more withdrawn when specifically asked about her delusions, appearing catatonic. Physical exam was unrevealing for any neurological abnormalities. Her catatonia improved with lorazepam. However, her delusions persisted during her hospitalization. We performed an extensive workup for any organic etiology for her psychosis, which was negative. Additionally, a urine drug screen performed at the time of admission was negative. The therapeutic alliance was built, and she shared that she was a Jehovah's Witness and that she had an order of protection filed against her husband. Hearing this, we became concerned about the possibility of intimate partner violence. After detailed exploration and discussion, we began to understand that this was a delusion. She later shared that the order of protection was actually from Jehovah. Due to the vulnerability of all patients experiencing IPV, we decided to hold a family meeting. Throughout the family meeting, she continued to make odd statements regarding her marital status, such as marriages can change day to day, and that she was not comfortable going home with her husband when she was deemed psychiatrically stable. Throughout this, her husband denied any IPV and thought her comments were secondary to her psychotic state. Out of concern for the patient and to further understand her psychopathology, additional collateral was obtained from the patient's aunt. Her aunt, one of her closest confidants, refuted IPV. Her aunt noted that the patient began behaving bizarrely 2 months prior to her hospitalization. Her aunt, who lived in a different state, recalled the patient informing her that she would be leaving her husband and moving in with her, which was uncharacteristic of her. Following this conversation, the patient's aunt reported that the patient had abruptly stopped calling her because she thought her phone was being hacked. This collateral and the patient's clinical presentation led us to identify this was either unspecified psychosis or a brief psychotic episode with catatonia in the setting of a recent COVID-19 infection. Her catatonia resolved with lorazepam and her delusions and paranoia resolved with haloperidol. Post-hospitalization, the patient was diagnosed with schizoaffective disorder. She was unaware during her hospitalization, but she has a family history of schizophrenia in her father and brother, as well as type 1 bipolar disorder in her mother. She has had no recurrence of her paranoia or delusion since her hospitalization. There have been increasing reports of psychosis after COVID-19 infection. Our case adds to the literature because we demonstrated one of the first reports of late-onset akinetic catatonia as a possible sequela of COVID-19, as well as successful treatment regimen for this disease. In addition, our case highlights how human beings are multifaceted, and as healthcare providers, we must consider the biological, psychological, and social aspects to completely treat a patient. While the focus of this case was on COVID-19 and the potential neuropsychiatric sequelae, it also highlights how culture is interwoven into the healthcare of our patients. This case also highlighted the importance of treating the symptoms in the absence of a complete clinical history. Late-onset akinetic catatonia after COVID-19 infection is a possible sequela of COVID-19 infection. We recommend lorazepam as a first-line treatment for this presentation. And this is our poster. Thank you for your time.